I thank to the organizers for giving me this opportunity, particularly to Dr. Murli. Well, as of now, I am working at Sri Sathya Sai Sanjeevani Hospital, Raipur, and you can make out this beautiful building. This is heart-shaped, and here we do about 6 pediatric open hearts every day. And in general, we come across at least one left SVC every alternate day. Now, this is the place where I learned my art and science of cardiac anesthesia. I am sure that everyone in the audience would be familiar with this place. This is Sri Chitra Tirunal Institute for Medical Sciences and Technology, Thiruvananthapuram. Well, coming to the topic, left SVC or persistent left SVC, T imaging. Now, before you go into T imaging, it is important to understand a little bit about its anatomy, its embryology, and how it affects the circulation, etc. So, left SVC is the commonest variant of systemic venous drainage, and it is present in up to 10% patients with congenital heart disease. Now, a bit about its embryology. During the fetal life, the upper half of the body is drained to the heart, that is sinus venosus or horns of sinus venosus, by the left and right anterior cardinal veins and left and right common cardinal veins, and they join the horns of sinus venosus. Now, during the process of development, the left anterior cardinal vein and left common cardinal vein, they obliterate, and the confluence of left internal jugular and left subclavian vein joins the brachiocephalic vein, left brachiocephalic vein, which joins the confluence of left and right internal jugular and subclavian vein and forms the SVC. So this is what is the final circulation in adulthood. But in patients where the left SVC persists, what actually happens that the left anterior cardinal vein and left common cardinal vein continue to persist, and this left SVC drains into coronary sinus, and through coronary sinus it drains into the right atrium. And since the coronary sinus is joined by the left SVC, the coronary sinus becomes enlarged. Now, a bit about its anatomy. You can make out here that the left SVC descends anterior to the arch of aorta and left pulmonary artery, and thereafter it descends between the left atrial appendage and pulmonary veins, and thereafter it joins the coronary sinus and opens into the right atrium, as I have mentioned earlier. Now let's talk about its T imaging. You can see it very well that during the, this is when you cut across, this is the 4-chamber view. And during the 4-chamber view, a little bit steering up the transducer, what you can see is the left SVC and maybe the coronary sinus on left side opening into the right atrium. So this is enlarged coronary sinus, and here you can make out that left SVC is joining the coronary sinus. Now here in front, you have to make sure that there is a left atrial appendage, and behind there is pulmonary veins. So when you do T imaging, you look for that pulmonary veins are behind the left SVC and left atrial appendage is in front of the left SVC. So just to repeat again, You visualize or you image the left SVC in mid-esophageal four-chamber view. You look for the coronary sinus in the same view or deep four-chamber view, and if the coronary sinus is dilated and measures more than 1 centimeter, it that indicates the presence of left SVC. Now there are several anomalies like tetralogy, VSD, ASD. They are associated with left SVC. This is another view, the same view, little steering. You can see the two parallel lines here. You can see the two parallel lines here. That is the vertical part of the left SVC. And this is the left SVC. Now in this image, it is important to understand that what you are seeing here, this is not the left SVC. Here you can see that pulmonary vein is in front of this rounded image. This is the image of descending thoracic aorta. So this is not left SVC. Left SVC is always close to mitral wall. Anterior to that is the left atrial appendage, and posterior to that is the pulmonary veins, left upper or lower pulmonary veins. So now let's see the problems associated because of persistent left SVC. Since normally the confluence of left subclavian and internal jugular joins the right SVC, the right SVC is quite large. But in patients where the left and right, they drain separately into the heart, the SVC is relatively small. And therefore it is difficult to insert a central venous catheter or a PA catheter or to insert pacing leads through the right internal jugular vein or right subclavian vein. So from anesthesia point of view, it is difficult to insert CVC and PAC in presence of left SVC1. From the surgical point of view, since the left SVC joins the coronary sinus and opens into the right atrium, that simply means that during the conduct of cardiopulmonary bypass, the left SVC will continue to drain into right atrium, and it will flood the field, and it will be difficult to operate, particularly the procedures done on the right side of the heart. And therefore, the right side, therefore, the left SVC has to be drained. So majority of the surgeons, what they do, they drain the left SVC either through coronary sinus, or they put in a separate drain into the coronary sinus into the left SVC, the way the right SVC is cannulated. However, if the bridging vein, that means the left innominate vein or left brachiocephalic vein is present, and the left SVC is joining the right SVC through innominate, in that case, it is not always necessary to drain. Just surgeons, what they do, they loop the left SVC and they snare it so that it doesn't flood the right sided field of the surgery, and the surgeon can continue to operate while the left SVC would drain into the right SVC through the innominate vein. Now another important thing is that since the coronary sinus is quite large, and if suppose surgeon plan to give a retrograde cardioplegia, it may be difficult to find a seal between the balloon of cardioplegia catheter and coronary sinus, and in that case, it will be difficult to deliver retrograde cardioplegia. Additionally, even if suppose say you may find a tight seal between the balloon of cardioplegia catheter and the coronary sinus, the cardioplegia solution delivered would spread into the systemic venous circulation and it will not be really effective. So it is very clear that in presence of a large coronary sinus with left SVC draining into it, it is not always a good idea to give retrograde cardioplegia. Now, because of the dilatation of the coronary sinus, there is stretching of the AV node and his bundle. There can be its fragmentation, and that give rise to rhythm abnormality. So it is important that these patients, when they undergo open heart surgery, one must be prepared with the possibility of rhythm abnormalities after the correction of the defect. One more important problem that can occur, that is the dilated coronary sinus can compromise the vestibule of mitral valve and it can mimic or it can present as mitral stenosis. Now there are some other problems associated with left SVC if it drains directly into the left atrium. That is what we call when the coronary sinus is unroofed. That means whatever the drain that is coming through left SVC, it drains directly into the left atrium. Now it is clear that normally when you put a cannula into the SVC and IVC for systemic venous drainage, it is put while the heart is still not arrested, heart is normally beating. But if suppose the surgeon tries to cannulate the left SVC while the heart is beating, the opening into the left SVC can entrain air and there can be systemic air embolism. That simply means that in presence of unroofed coronary sinus, the left SVC should be cannulated only after the heart has either fibrillated or the heart has arrested. One. Now if any drug is injected through the left side, like say cephalic vein or basilic vein or left internal jugular vein or subclavian vein, it can find its way into the systemic circulation. Normally what we do when we give drugs into the circulation, it passes through lungs, then it reaches to the left side and circulated to the body. But in this case, the drug will go directly into the systemic circulation. Similarly, if suppose say air is also there in the syringe, little bit of air is there, that will also find its way into the systemic circulation and can result in air embolization. Now the large communication or large, the drain of left-sided circulation, left upper half of the body circulation into the left atrium mimics as intracardiac right to left shunt, because the blood that is coming through left SVC is deoxygenated blood, mixes with the systemic oxygenated blood that is reaching to left atrium, joins it, and it causes desaturation. So it increases its right to left shunt, mimicking similar to ASD. And in presence, another thing is there is always a possibility of paradoxical cerebral embolism. So to summarize, left SVC is a commonest variant of systemic venous drain. Left SVC is easy to image in mid-esophageal four-chamber view. Left SVC need to be drained during right-sided open heart surgery. In presence of left SVC, it is difficult to deliver retrograde cardioplegia. And if cardioplegia is delivered even in spite of that, it will spread into the systemic circulation. Therefore, the protective effect of myocardium will be compromised. And in presence of left SVC, there is always a possibility of systemic embolism and drug delivery in systemic circulation if left SVC opens in left atrium, that is in presence of unroofed coronary sinus. Thank you very much for your kind attention. Thanks a lot. From you.